Welcome to Navigating Clinical and Operational Challenges of a Global Health Crisis webinar. I am Andrea Lowe, the Director of Employer Strategy here at AAPA, and thank you for joining us today. I am so delighted to host this webinar with two dynamic PA leaders. Our first speaker is Jennifer Orozco, who is the Director of Advanced Practice Providers at Rush University Medical Center in Chicago. Prior to this leadership role, Jennifer was the founding director of clinical education for the Rush Department of PA Studies and the director of PA clinical practice for medical affairs, where she helped solidify both the PA program and the AAPA role at Rush. She has been a practicing PA in vascular surgery for more than 17 years and has tremendous experience on both the state and national level. Jennifer is the former president and current legislative co-chair of the Illinois Academy of PAs, an appointed member of AAPA's Commission on Government Relations and Practice Advancement, as well as director at large on AAPA Board of Directors. Our second speaker is Christopher Anderson. Christopher is the Senior Director of Advanced Clinical Providers at Northwell Health Lenox Hill Hospital in New York City. His clinical background includes surgical work at Montefiore Medical Center Residency Program, Jacobi Medical Center Surgical ICU, and Northwell Health Southside Hospital. Prior to coming back to Northwell, he was the director of APPs at Memorial Sloan Kettering Cancer Center, with a major focus on APP professional development and operational efficiency related to inpatient hospital operations. Thank you both, Jennifer and Chris, for being here today. Just a few housekeeping items. There will be an interactive question and answers at the conclusion of this presentation. If you have a question for Jennifer and Chris, please use the Q&A feature through Zoom to type out your questions, which Katie Desmond on our AAPA staff will ask our speakers at the end of the presentation. You can, however, use the chat feature throughout the presentation to ask questions of AAPA staff or share resources with other participants. But please remember to place your specific questions for the speakers in the Q&A feature. With that, I will hand it off to Jennifer.
Good morning, everybody. Give me just a chance to share my screen here with all of you. Thank you so much for that wonderful introduction, and I appreciate you having me on this webinar today. And so, you know, I'm very lucky to be presenting with Chris, who is in New York and is a wonderful PA leader out there. And we, as many of you, have been going through, you know, the COVID crisis, as well as some others that have been occurring over the last many months. And so what we wanted to do today is really share our stories with you so that maybe if you're experiencing this in whatever timeline or fashion that you're in, you can learn from what we did, as well as some best practices and maybe some advice for the future. So let me first start by saying, so I am the Director of Advanced Practice at Rush University Medical Center, which is in Chicago, Illinois. I have about 400 advanced practice providers, which is all APRNs and PAs here at Rush, and work very closely with the senior leadership team. And I'm very lucky in my role in that we work very closely with leadership for provider services across the medical center, which was key in this pandemic. And so what I wanted to start off by was really talk about a couple of things. One is identifying what we needed, what teams we were going to have, and how we were going to support them as we started to take care of this influx of patients coming into the medical center across the system, and then how we were going to manage that over the next, what was anticipated, several weeks, if not months. And then as we started to dial down with our numbers, how did we then pull back on those services strategically and reopen our care to patients, as well as recover financially? So I know that's a lot in probably my 20 minutes before I hand it off to Chris, but we're going to try to cover and share some of what we learned. So the biggest thing when we had the first patient enter the medical center, which was probably about early March, if I recall, was we stood up our hospital incident command center. which is really made up of many of the senior leaders and directors across the organization. It's really a small army of about 30 individuals, physicians, nurses, IT, communications, advanced practice providers, you name it. This group of 30 really was there to really start saying, what do we need to do and how do we need to do it? So the first step that we did was identifying what we needed and how we were going to do it. And I'm going to focus right now, and I'm on providers in particular, are both our APPs and our physicians as part of this discussion today. But really, this was a very highly coordinated, proactive effort by the Hospital Incident Command Center that broke off into groups with individuals who could take on these tasks. And so part of my role as Director of Advanced Practice was to partner and really work on the provider specialty arm. And so what we did in the first phase of this was identify what we had and what we needed. And we, as you heard, are a large academic medical center. So not only do we have attending physicians, we also have residents, we have advanced practice providers, and we have students that were here in the medical center when the pandemic hit. And we knew that there was going to be, and this is from lessons learned in New York, which Chris is going to talk about in a moment, but we knew the critical areas that we were going to have to stand up in regards to our COVID patients. And one was the emergency department, our hospitalist team, which was going to be taking care of everybody admitted to the medicine or the surgical floors, as well as our critical care teams, which were going to have to do some heavy lifting. Now we have about 1,800 providers, both physician and APP, and then an additional probably 1,000 or 1,500 or so residents across the system. And what we didn't want to do was really have everybody fighting over who was going to pick who, and making lots of phone calls. Did we want to take volunteers? Were we going to reassign people? So what we did was we brought together a group which I was lucky to be involved in as the director, as well as these three areas. So our emergency medicine chairman and our administrator, our hospital medicine chairman and the administrators associated with that, and then the ICU director, and then all of the GME, the 2 GME directors that we have that helped coordinate this effort. And so we really spent a good probably 2 days deciding which areas of specialty for both physician and APP were going to be assigned to each area and what fit best given their skill set and their expertise. And as you can see here, our emergency department, we needed individuals who could really take care of patients from birth to geriatrics. And so we thought of our primary care colleagues, as well as our general internal medicine colleagues who had the most experience from across the spectrum. And then hospital medicine, which needed some acute care training. So our medical subspecialties and which ones would be the best fit for hospital medicine, as well as GME and residents. And then what our critical care folks who had the most experience when it came to critical care, which honestly fell with our, obviously our medicine intensivists, as well as our surgery folks who were very experienced in the critical care arena. So we spent a good 2 days really mapping out all of these individuals from across the system so that we didn't have competition over who was going where. And we were very thoughtful and deliberate about contacting these areas to say, here's where we're going to go and here's what we're going to stand up as we start to move along. After we had done that and really gone through that exercise, and I have to say we had a lot of support. I had a project manager that was working with us that really helped coordinate those efforts and help with communication and really putting everything on paper, which was what we needed as we started to move along. So after we had identified who was going where, we really broke out into 3 buckets, and we needed to give those areas support about what they needed, right? We didn't have the experts. We were pulling people from other areas of the hospital to work in these areas. And so what did they need? And really kind of down to the basic level of, you need PPE training. Does your badge work on the floor? Do you have the right EMR access? And really kind of the basic administrative level function. And then the security or the clinical level function, right? So did we have materials and could we get these individuals trained and up and running very quickly so that the APPs and the physicians who weren't used to working in those areas could feel comfortable taking care of patients. And what kind of support would we offer them during their shifts as they continued to move along, so that if they ran into issues as they came up, how could they really get through those issues both clinically, administratively, and really provide the high quality, safe patient care in these areas. And so our ambulance bay, or what's known as our Brennan Pavilion in our tower, is where we put our patients that came into the medical center through the ED. And we had two areas of screening. We had one major area of screening which identified our COVID patients, and it was really our triage. And so those that were not very sick got triaged by the advanced practice providers. They got swabbed, they got education, and they were sent on their way. And the others that the APPs really took a look at and assessed that needed a higher level of care went to the main ED, where they were taken care of by physicians and residents and APPs who worked in that area normally, and then would decide whether they got admitted. So this was really up and running for our entire pandemic with the ambulance bay. And then we had hospital medicine and critical care, which had a little bit more education and training. We had developed online modules, handbooks. We allowed them some face-to-face shadow time before they were independent, but really gave them everything in a one-stop shop of here's how your crash course in hospital medicine or critical care medicine, and here's your partner as you continue to move along throughout the pandemic. This here is what you'll see, and I'm sure you've seen this graphic. This is from the Society of Critical Care Medicine, and we really stuck to this tiered staffing strategy for all of these areas, which was really putting that ICU or hospitalist physician or APP expert that's really at the top of the pyramid, and then adding individuals as you started to go down in areas that really didn't normally work in those dedicated areas. And so this really pyramidal support of both nursing, respiratory therapy, our CRNAs, you name it, we had these tiered individuals, especially in the ICU, as we continued to provide care. The other piece of this, which I think was probably the biggest challenge, is really a technology piece, right? Is we have these thousands of people, both clinical staff and non-clinical staff. We have students and employees that all work throughout the medical center. And as everything really came to a halt, but we needed to provide this patient care, we needed to figure out how we were going to manage this large database of individuals, and what did we need to do. So I'm going to talk about it in another slide here, but really, it was creating the technology that we could have a one-stop shop where I could look up any staff, employee, student, whatsoever that had the skills that I needed to take into another area, and really track them all the way down to what hours they were doing, et cetera, as they started to move along in the pandemic. As we also looked at redeployment lists, we needed a very detailed assignments, right? We need to know where these people were, what was their job title, when did they start, when were they ending, and from a provider standpoint, we also needed to make sure that everybody was privileged to do what they needed to do throughout the medical center. And so, as you know, most of the executive orders in the states allowed, we had disaster privileges for our physicians and our APPs throughout the medical center, which allowed them to provide care wherever we needed it. And I will say that probably the one thing that really came out of this as I sat in hospital incident command meetings was really the flexibility of PAs and the APRNs to move across the system, and PAs in particular that are trained in a generalist model and could take care of anybody from infants all the way to geriatrics. And this is really the key here, that people really felt that we had these advanced practice providers, they felt comfortable with them, and we could move them wherever we needed to. So every meeting I went into was, where can I get more APPs that we can help to combat the number of patients that we have coming into the medical center. And so you'll see here, this is just a screenshot. This is one of the OneDrive Excel spreadsheets that we had that allowed us to track where these APPs were by their employee ID number, add some notes as well as their deployment start and end dates, as we needed to keep track of finances and everything related to COVID. And then what their FTE breakdown was and how many hours we had for each person. So you heard me talk about technology, which was, we used the Microsoft OneDrive technology, which really allowed us, similar to a Google document, to have live documents that anybody could look at and make adjustments to as we were moving and changing every day. Information was coming so fast, right, both at the state and the national level, and things were being updated every day, from the schedules to the treatment for COVID patients to people moving in and out of roles as we started to move along. So we needed a live document that everybody could look at and update and change as needed. And I'm going to show you here on the next page really quickly that what the OneDrive document included and how that really helped us as we continued to move along here. We also created a separate email, and this was actually really helpful. We didn't want people kind of emailing back and forth in their own personal email inboxes at Rush, and so we created a labor pool command center email list, which was managed by our administrative assistants, which could really track all of the requests coming in throughout the institution, or if someone was calling off or somebody needed some accommodation. It allowed us really a one-stop shop to track and really maintain databases and all of the details that we needed. So you'll see here in this OneDrive technology, here was our areas. We had a leader over each areas, and I'm proud to say that most of the areas that we had, the lead contact and the person managing that area was an advanced practice provider. And this really was a game changer. Having a provider as the lead over that area allowed people to make adjustments in real time, as well as had an understanding both clinically and administratively what was needed. So we used our lead advanced practice providers in this area to help manage and staff what the needs were. And they were in contact with myself, who was over provider redeployment, and really allowed that real-time change. You'll see at the bottom, we also created templates of scheduling for each one of these areas. And so anybody could pull up the schedule at any time, see who was on, make any adjustments as needed, so there wasn't so much back and forth between emails. The OneDrive technology also allowed us, and this was really a partnership with our project manager, to build this OneDrive, and she had done an amazing job at building this, as well as all the formulas that go into this. But this allowed us to really look at everybody's FTE, the hours that were available, and what was needed, and manage each one of these areas as we continued along. So what we started to do is really create a labor pool command center, and we needed someone to manage this. And this was not only in charge of provider redeployment, this was in charge of all non-clinical staff redeployment across the system. As most of you know, we had, and have probably done at your institution, we had temperature screeners. We had a prone team that helped with our critical care patients that needed to be proned. We had a security team, and we had all different folks who were on all of these teams. So this labor pool command center was really an army in itself, a small army, where we had one director who actually happened to be an APP, as well as 3 managers, which were my department administrators, who agreed to help manage daily tasks as well as schedules and work on workflows and anything administrative that we needed. Our project manager, which maintained our databases, and our administrative assistants. Because remember, most of these people weren't necessarily working because clinics were closed. And so this allowed us to take individuals and keep them working during the pandemic. That really helped as we started to move along in this kind of team effort. And so the labor pool command center was really key with communication. We had a daily huddle. It allowed us to identify crisis needs or any urgent needs of any one of the areas. So each of the team leaders from across the organization would meet on that daily huddle, as well as ask for any kind of staffing urgencies or changes that needed. It also was a way that we communicated with them weekly with email and managers, and allowed us to make changes in real time. This was the workflow that we built for that COVID, really virtual staffing request. So if individuals were short, if the ICU was short on nurses or PCTs or APPs or a physician, this request would start, and we shared this workflow across the medical center with an email into that email inbox that I mentioned, and then it was really taken into that labor pool command center, who would notify staff and make changes and coordinate all of the communication from really a one-stop shop with this. And that was really key as we continued to move through this. So let me talk about surge recovery and opening in my last few minutes. So as we moved along in the pandemic and our numbers started to go down, we needed to get people back to work, right? So not only did we have to maintain these simultaneous COVID units that still continue today, although not at the same level that we were at the height of the pandemic, we had to find a way to balance what was going on with COVID, as well as reopen to allow clinics to reopen and surgical, our surgical cases to ramp back up. And so, as you remember, when I went back in the beginning, how we identified who was taking care of each area, we had to be very thoughtful about what teams and in what order could be stood down or needed to be maintained as we continued to recover and come out of this. And so this was really key to us coming together as the Hospital Incident Command Center and saying, how are we going to determine how we release these people back? And as you can see, we created really set points for release of providers, and that was how many beds we had that would help really determine our staffing models, and then what was coming into the ED and what was going in at the state at the time. So we created back to, similar to that Society of Critical Care Medicine, you'll see, really this tiered approach to what was considered essential, what was transitioning, and what could be absorbed by each one of the departments as we started to move along. And so, and I can imagine that this would be different for everybody, depending on what's going on in your state or in your institution. But this was our approach to this, which worked really, really well and allowed us to really release people back slowly and maintain operations at the same time. So, as of everything, as every pandemic, and hopefully we never have to go through this again, but there's always an opportunity for learning. And we're always learning and trying to figure out what could we have done better. And these are some of the points that when we met as a team and when we stood down that labor pool command center, we got together and said, hey guys, what can we do better? And I think communication is probably one of the biggest things. I'm only one person. The Hospital Incident Command Center was a team of 30, but nonetheless, we have thousands of people we have to communicate with. And with how much and how fast things were changing with COVID, it was almost impossible to keep up with communication. And really, I think one of the keys is identifying early what is the best method of communication, whether that's email, whether that's texting, whatever it is, how frequently you're going to do it and how often you're going to do that. So, and I would say that err on the side that over communication is better than less communication. So we identified definitely we could work on our communication itself. The database, again, the amount of labor to maintain and up that on a regular basis really needed more than one or two people that were doing that. And so you really need a small army of individuals to keep that updated as frequently as possible. We obviously had vulnerable employees, so those with high risk medical conditions that could not necessarily be patient facing with our COVID patients. And so we needed to define what that meant, as well as develop an accommodation process to meet those needs so that it was fair and equitable across the system. We did a good job with this, but I think that we could have really, really defined in greater detail what we were doing. Compensation is a big one, right? You know, when we started the pandemic, everything was really volunteer, who wants to help? And then it really turned into, this is what we're going to do moving forward. And we needed to identify early compensation models. And I think we could have done that, and not just for APPs, but for physicians, nurses, what have you. We really could have done that a little bit earlier. Instead, we played a lot of catch up at the end. Everybody did what they needed to do. Nobody really was barking over whether they got paid or not. They were happy to continued to be employed, and really just wanted to take care of patients. And so, but it really is important to define that model early. And then, you know, if this happens again, what does it look like in the event of a resurge? We know COVID's not going away. It's going to be around for a while, if, you know, probably another year, if not more. And so what does it look like if we resurge again? And then FTE taken into consideration. So as we start to think about flexible staffing models, it's very important to consider how much FTE an individual has that you can use, and what's available as for provider redeployment. So with that, I am happy to answer any questions as you type them into the box, and I am going to turn it over to Chris.
Hi everyone, just figuring out how to switch this over. All right. Well, welcome everyone, and thank you for joining us this afternoon. Same title of presentation, which I'll go through, and you'll see a lot of similarities that exist of what we did in New York City during our COVID surge back in March and April. With that, we'll take you through what we did for unit staffing designs, FTE calculations, ACP identification for deployment. Obviously, we have a lot of hospital-based advanced clinical providers, NPs and PAs, but we also have a large ambulatory contingency in which we called upon during our deployment strategies. Share some deployment statistics, how we track deployment, some of our new unit models and care models we deployed, how we leverage digital virtual communication, and what recovery and second wave planning looks like here for us in New York City. So this is just a map of what our entire health system is comprised. Many hospitals spread out a large geography, all of Long Island, Westchester, New York City, Staten Island, and broken down into several regions. So the 3 arrows represent an eastern, central, and western region. And we'll be focused mainly on the left lower corner circle in New York City, focused on Lenox Hill Hospital, Manhattan Eye, Ear, Throat Hospital, and Lenox Health Greenwich Village, which is a freestanding emergency room in lower Manhattan. The two red arrows represent hotspots that had very high COVID numbers when the pandemic started for us in early March, which led to a lot of shifting of patients and overwhelming of some of the facilities in just terms of sheer volume on a day-to-day basis. But you can see that the two hotspots were mainly where all of our hospitals are on Long Island. We were fortunate that our rise in COVID volume was a little bit delayed in Manhattan in comparison to the other surrounding areas of the Metro New York area or Long Island. And allowed us to really leverage technology quickly to begin our identification process. We actually, hold on one second. We actually started with cross-credentialing of all of our providers in different hospitals, whether that was in New York City or up in Westchester, just to allow flexibility before the state laws change, allowing disaster privileging to take place and the easeability for us to flex staff between locations. There was major partnership with HR and medical staff, and we generated a list that we were able to identify locations of staff, where their ambulatory practices were, where they lived, so that if we were going to deploy in different geographies, we would do so in accordance to where they lived to make their commuting a lot easier. There were times when commuting into Manhattan was challenging, whether the mass transit systems changed hours or even shut down the subway overnight, which just raised issues with getting around the Manhattan or even coming into the city from Long Island or Westchester. With technology, we started creating new distribution lists similar to what Jen did in Chicago, and really leveraged our new communication strategies to make sure that staff was engaged and aware of what was about to happen. We started deploying competency identification spreadsheets to staff to learn what they were able or not able to do. We wanted to know not only cognitive competencies, whether that's managing certain types of patient populations and acuities, but other procedural skills they might have as we started to develop new types of teams within the hospital. And then from there, we just developed competency level teams to work on certain units. So all of the patients in the hospital, upwards of 300 to 400, were all COVID-related patients, with very small subspecialty patients in the hospital, especially when elective surgery was stopped. So the units just became acuity-based, and we started staffing like that. And I'll show some examples of what that looks like. With that, we created a new table of organizations with new managers that led teams of people that they haven't led before. And they were mixed teams of both ambulatory and inpatient providers that just came together as a newly formed team by acuity. This is one of the spreadsheets we created. Similar to Jen, we use OneDrive and cloud-based folders to share and save our documents. This was sent out and then compiled for the 150 to 200 or so providers just in Manhattan that we had fully redeployed. And we took each of their skill sets, what their primary service was, what they've been managing currently, what they might have managed in the past. Believe it or not, there were several outpatient ambulatory providers that had once worked in an ICU and had different types of training and different types of procedural skills that we could definitely lean upon and utilize within our hospital as a team formation adapted to the volume shift that came with COVID. From there, more leveraging of spreadsheets and just organization of staff. You could see on the left, we organized teams by ICU and step-down capability versus telemetry and regional capability. And then on the right, you could see the new teams were formed based on color coding, so that it was very easy when we started sharing these documents of the service. They knew where they were going based on color coordination, that there was less room for confusion. Our staffing designs and FTE considerations, we had multidisciplinary meetings daily with chief residents, as well as medicine, surgical, physician leadership, and the GME leadership of the hospital to start looking at what each of the units were in the hospital that we were opening or closing at any given time. This is one example of our one of our units in the hospital where we have what type of unit is it? Is it COVID or not COVID? The bed count, the acuity level, staffing needs, what the staffing is during the day, what the staffing is at night, and basically flexing depending upon what the acuity or type of unit that it is. And you can see there are multidisciplinary team members, whether that's attendings or fellows, urology residents, surgery residents, medicine residents. This one has a whole conglomerate of staff that is taking care of the patients on this unit. And as our staffing counts change and our deployment strategies continue to escalate, our available staffing allowed us to shift different teams around and make different care delivery models happen. We also had to take into account, as staff got sick, how that would affect our staffing models, and were we plugging in a house staff member or advanced care provider into the care model. It would all depend on skill level and competency for which we were replacing team members with. What we did, this is a basically look at of each of the units by day and night shift, bed counts, and what the staffing need would be for each of those units. And this shifted as the units opened and closed depending on resident staffing or not. And this is just a summary of by day to day, actually bodies needed per service, and just a basic FTE calculator by calculating shifts needed by hours for that shift, and then just calculating the total FTEs needed so that when we were deploying based on acuity, so again, our acuity color coding matched our staffing deployment, we were able to count, you know, for ICU acuity, we needed 15 FTEs. We would find 15 providers to allocate to that new management team in order to deploy their staff to those units. And it became very fluid, but it was very clear cut on what we were doing because we just remained organized and concise each and every day that we came to work. And this was a constant, everyday, twice a day challenge that we continued to face. But remaining organized and constantly communicating, we were able to do this very successfully. Some local deployment statistics in just the Manhattan market for Northwell. We had 114 advanced care providers from inpatient reporting to new units and teams. We had 91 ambulatory identified ACPs and deployed 62 of them. Others remained in clinic. Their physicians were actually deployed, especially in the pulmonary group. All the pulmonary critical care attendings were deployed to manage ICU patients, but they still had patients that needed care on the outpatient world. So those ACPs remained in those clinics in order to take care of patients and still allow access to care to happen during the pandemic. We always had a mixture of staff that were sick or on furlough and other staff that were just unable to deploy for a certain number of reasons. If you can remember from the graph or the picture in the beginning of the slide deck, we were broken into multiple regions. In total, we deployed 500 ambulatory providers throughout the entire health system. And this is just a breakdown by region, but you can see that that's a lot of work that a lot of people took part in. And I'm just giving a snapshot of what we did in Manhattan, but there is a larger level ACP leadership structure for the entire health system, which we all work together to ensure that staffing met the needs of each of the individual hospitals that were taking care of patients. One of the nice things about working for Northwell and working during this pandemic was the ability to innovate as well as provide care to patients during a pandemic focused on ACP care models only. If you remember in the news, we had the Javits Center that was rolled out to take patients. I was fortunate to go visit there. It was really a phenomenal job that they did there in order to help decompress our hospitals. But with that, we looked at development of these CAP units where COVID awaiting placement as the governor held us to holding patients waiting on COVID testing. And during March and April and May, COVID testing was very difficult to come by. We were reserving tests for the sickest of the sick, and reagent supply chain was very short, and it really delayed us with getting COVID results, where today we can get test results back in a few hours. We were waiting days sometimes to actually get results back. So we had patients that were stable for discharge but awaiting their COVID testing, and that forced us to have to hold the patients into different units. So we actually created an offsite unit at an ambulatory surgery center, reconstructed it in several days, and developed a new care model focused on our orthopedic ACP team at the hospital. And it was run by ACPs. There was a hospitalist that volunteered his time to come and round several hours a day, but the 24-hour operations were run by the ACPs with code and rapid response backup from our freestanding ED, which was in the first floor of the building. We moved 80 patients out of our hospital over 3 weeks, and we were discharging 5 to 6 patients a day, which was really remarkable for a team taking care of a new patient population and being able to facilitate their discharges, family communication, and just overall medical care day to day in a high quality new care model. With all of the things were going on, communication was a major source of ensuring that staff had the support they needed to be successful in the new roles that they were working. Many of the ambulatory staff were now working nights and weekends where their normal jobs were 4 or 5 days a week, 9 to 5 or 8 to 6 or whatever their schedules were. But we wanted to ensure that they knew what was going on. We really leveraged digital communication via our virtual portal like we're using today, and had town hall events with them every week or every 2 weeks, depending on how much stuff was changing. Engage with HR to create standard written communications about the updates that were happening, whether that was updates with childcare benefits, transportation benefits, how we could park on the New York City streets for free, everything that was changing, very rapidly. We wanted to make sure we looped into this communication and made sure that our staff was up to date, because when they came to work, they were wrapped in their masks and face shields and gowns and gloves, and having them be able to check their emails or even text and call them was very challenging, as they were in these units just taking care of patients. So we wanted to really condense all the important information and send it out to them. On the leadership side, we had twice-a-day calls that were done virtually to ensure that everyone was up to date on what the executive team was planning for. And this allowed us to change our care models and deployment strategies very quickly. And this happened 7 days a week for about 2 months. And just leveraging our technology, our cloud and share drives to share documents and updates. And I already mentioned the town hall events. So again, it's a big thank you to all the ACPs. We got a lot of food donations. It was a lot of fun. People felt supported, and I think we all bonded through it. But as the COVID numbers came down, we started getting into what recovery looked like for our hospital and our health system, which was a major important factor in the financial success for our future. To be able to support, staffing and keeping the doors open, we had to start getting patients back into the hospital that needed care that was delayed with COVID. This is just a timeline of what it looked like. On the bottom left in the red diamond is when cancellation of elective surgery happened on March 16th. Our first patient that we had here was on March 7th. So that just shows you that we ramped down surgery very quickly. With that, it wasn't until April 28th where we started to be able to do priority 3 and 4 cases at Lenox Hill Hospital. And on April 30th, we were able to do them at Meath. And these cases were the cases that could not wait without patient harm actually happening. So these were very sick patients that needed care that had been delayed while we were in the midst of the pandemic. And you can see how long it took before we started doing lower level cases into June. And on June 4th, we were given our elective surgery waiver, where we were able to sort of get back to normal business operations now that the COVID numbers had dropped off substantially. This was a really great time. We formed a new command center that was just based on surgical recovery, a multidisciplinary team that came together and really utilized our team bonds to ramp back up operations quickly to get the hospital back to where it was going and redeploy staff back to their normal services to feel like they were working in their normal jobs again. Part of surgical recovery, we created surgical case approvals. I was actively involved in this, and it was a nice process of where we had database of cases, and we would go through and approve cases to be done and expedite their facilitation through the OR to ensure patients were getting the care that they deserved in an expedited period of time. We leveraged our project management team, who created a lot of different dashboards for us. And this was something that we were able to create on just our snapshot of surgical recovery of what was completed and still pending to be done, and gives us a little view of what was happening in the hospital as far as census and COVID census, and then what scheduled OR cases that we had and where they were expected to go. One of the big factors was that our ICU census remained very high. So facilitating cases that required ICU heavy length of stays, we were thinking about doing at other sites to be able to still offer ICU capability if sick COVID patients still came in. So through algorithms they created based on historical data, the ability to evaluate patients who were having certain types of surgery and where they would go after the operating room. And that was important as we continue to schedule and ramp up case volume. During this process, we found that many patients still did not want to come for surgery. So with some of our furloughed staff that were not able to work due to medical conditions, we had them home helping in different ways. Many of them helped with some of our spreadsheet formation and management, reaching out to staff to replace them or find other work for them. But we also used to call patients and figure out what barriers were being created because they didn't want to come for surgery. So really good data was obtained. We used the opportunity to educate patients on our COVID testing capabilities and the safety measures that we put into place, and really just alleviate fears. But you can see that 19% of patients wanted to reschedule, or they wanted to reschedule, and 24% said that they would schedule. So it's still a large portion of patients that if we had not contacted, it didn't give us the opportunity to talk to them and facilitate the care that they needed that had been delayed through COVID. And this is just a list of concerns from patients that really led us to changing some of the ways that we do business here at Northwell. Obviously, concerns of community spread, there's always scheduling issues that occurred, but visitation continued to pop up where we were very limited on visitation after the COVID numbers came down. During the pandemic, there was no visitation, but we actually utilized some of this data to create new innovative visitation waiting areas and different things to allow visitors here, as we found that patients being able to have visitors prompted them to want to have surgery and come in for their elective care at the hospital. And then others just really had issues that were still related to COVID. They might have COVID, they might have just gotten COVID, so many of their surgeries or procedures were rescheduled. So after recovery, we are in the process of second wave and resurgence planning and preparation. We formed 16 teams at the hospital to really relook at everything that we did during the several months of the pandemic and how we can improve upon that and have more preparation. We have clinical care teams. We're standardizing treatment algorithms and different opportunities for different team formation to facilitate care. And then any other community outreach. We're leveraging data and building data portals so that staff can have access to our dashboards and worksheets and documents and everything that we want to share with them. And just looking at all the different areas, whether that's from equipment to the lab, to our facilities, to pharmacy, PPE, and always the crux of everyone's days in the hospital is COVID testing. We are continuing to leverage our abilities to plan, prepare, and be better than where we were when we went through this the first time. So with that, we'll take some questions. I'm just unsharing my screen. Hold on one second.
Thank you so much, Chris and Jen. That was some really great takeaways. I'm looking to see, I don't think we have any questions in the chat as much at this time. However, if you do have questions, please feel free to put it into the chat. One question that I did have is, can you share some best practices that you all did when it came to checking in on staff and the mental health well-being? You guys shared a lot of best practices about clinical outcomes, which I think is fantastic. But can you share some of those tips that you did during this as well?
Sure. This is Jen. So, you know, we are very lucky here at Rush. We have a chief wellness officer. And we also had one of our APPs who is really in charge of our psych consult team. And so they created a wellness rounding team, which was made up of several psychologists, psychiatrists, as well as the chief wellness officer. And they essentially rounded 24/7, various different units, inpatient, outpatient, and really checked on the well-being of staff. We had frequent communication. We set up wellness hubs throughout the medical center in different areas that people could just go into, have safe social distance and relax. It was very spa-like. We turned a couple of just like our waiting rooms into more of wellness rooms where there was food and access to just unwind and, you know, talk to loved ones or whatever people needed at the time, as well as obviously our employee available resources, just making sure that that was well known to each one of the employees across the medical center. But I think the wellness rounds really made a difference for a lot of people, and people just coming by and saying hello and how are you and talking about their struggles, because life was still going on outside of outside of the hospital. They're taking care of all these COVID patients, but they were also dealing with family life. I had many that had just come back from maternity leave that couldn't go home to their newborns, and some others with, their risk of COVID, and they were very torn on what they should do. And so people really had a lot of struggles, and I'm sure Chris can even attest to that in his own hospital and some of the struggles that happened there.
I just got a meeting invite for a COVID expansion meeting, since volumes are starting to go back up a little bit in New York. We did a lot of similar things. Initially, we had a lot of food donations coming in. I felt like we were well fed, and that was a great thing for staff, is that all the units had food delivery. We set up a hallway where food would be breakfast, lunch, and dinner was delivered for staff. We even set up like a little coffee station in the hallway of my office so that staff could come up and get coffee or snacks on the overnight, since in the middle of the pandemic in like April, the things in New York City you feel that are open 24 hours a day were closed at 5 o'clock at night. So you couldn't even get a cup of coffee later in the night or on the overnight hours, where typically you could walk outside and there's a Dunkin' Donuts, a Starbucks, and 9 other coffee shops in 500 feet. That was a huge displeasure for staff. So we got a lot of different donations and offered it up to staff, and throughout it, towards the end, we started doing those things. Wellness rooms, our psychiatry department started showing up to all of our unit huddles and offering free service, and we would constantly talk to staff and see who was struggling or dealing with the stress of it. But we really utilized the time to, when we were ramping up or ramping down, depending on how much staff we had deployed, giving people basically furlough days off, especially as we ramped back down and we didn't need the staff. If we didn't need staff here, we sent them home or we didn't have them come to work. And we were okay with that, because we knew that that was important to preserve them in case things got, the volumes went back up very quickly.
One of the other things that I think is really interesting that we had happen here in Chicago, which I'm sure many of you heard about, is right in the midst of the pandemic, as it was winding down, we had the civil unrest and the riots that were going on in Chicago. And so it added this level of where we thought we were coming down from the pandemic. We had to immediately ramp back up because streets were closed. People couldn't leave their homes. We didn't have staff that could come into the medical center. We needed extra security. We started to provide Ubers and pick people up and walk them to their cars and all of those types of things. And this went on for a number of weeks, and it really added to the stress level of the employees here. And so the wellness team, just as Chris said, and why food is so important, it is like you give people some food and some coffee and they feel okay. So that was a constant, and we had so many donations. I can't tell you how many times philanthropy was calling with, we have more food for you. And so it was, and that was the, just the little thing that the community did and continues to do. And it is so helpful, and that continued, and we were so grateful for that. But yeah, it makes it really, really challenging to have that balance of taking care of patients and then taking care of your employees at the same time.
Yeah, there were times where I remember days we didn't have time to leave the hospital to go get food. So having it here was really nice, and having it delivered to the units was great, because they can just eat and work, and they didn't have to worry. They could just worry about the patients that they were taking care of.
I can tell you and this is kind of putting myself out there just a little bit. I think one of the things that I struggled with as a director was, I had these 400 people, and because I was part of this leadership team, I was like, all right, I want to get out on the front lines and start taking care of COVID patients. And they're like, no, we need you back here, like coordinating efforts. And it was a struggle for me, as I've been a PA a long time, that I was sending these individuals to the front lines. And I have many of nights where I was, wallowing in my sorrows over it, because it was so hard as a leader of the organization to know that I had all of these individuals and we really just didn't have a choice. We had to take care of these patients. But even my own wellness in that sense, it was probably one of the toughest things I think I've ever had to do, was really send all of these people to the front lines and put them at risk. And we all know that. I mean, it's part of the oath that we take and we're okay with it. But I have to say, as a leader, it was a struggle and continues to be, as we know this will probably ramp up again. And how do we take care of those people moving forward? I don't know, Chris, if you felt that same way at times or what, but I know that was a struggle.
I asked to work clinically and they told me no.
I know, me too. It's hard.
So much, and I don't think I could have been successful doing all of the deployment while trying to work clinically. I did go on the units every day. I rounded every day, and just made sure that people felt supported. But there was so much activity going on and change happening from day to day. And then I was in charge of the unit downtown, so there was days where I was driving back and forth between sites to make sure that things were, operationalizing the way they should be.
Yeah, those are some great tactics. Katie, I think we have some questions in the Q&A.
How do you ensure students can remain on clinical rotations and how can they be utilized?
This is a great question. We canceled all of our student rotations, and this was really for the safety of them, safety of our staff, and conservation of PPE. I know there's a PPE question later in the boxes, but PPE was definitely a concern from adequate volume, and we really made sure that whoever was here in the hospital needed to be here in the hospital, and that was something important. And at that time, student education was not something that we felt was safe for them to be involved with all these patients. We don't know a lot about the disease. We were doing a lot of different clinical trials. We didn't have any PPE to spare. Every piece was highly sought after and utilized to its fullest. And going forward, I'm not sure if we went through what we went through that we would continue rotations during those times, because we have to take care of patients as they come first, and all of the additional resources for part of student education during a pandemic, I don't know if that would be worthwhile in an inpatient environment.
Yeah. And just to dovetail, we had a very similar philosophy here. One, as Chris mentioned, that we were waiting days for testing to come back. And so until testing was going to be widely utilized, we couldn't take the risk of putting students, patient facing. The other thing was we minimized employees going in with those patients in the ICU. I mean, they had a team of residents, physicians, attendings, you name it, but we would only let one provider walk in that room. And there was not a team of people standing there over a bed of a COVID patient, discussing it as we normally would. And we were very minimal the contact with the patients. And so it just was too great of a risk for the students at the time. We were lucky to have enough PPE no matter what, but again, everything was changing so much and so fast and so rapidly. You didn't know what was going to happen the next day. And so we just couldn't have all of these people in that learning environment at the time. And so even now, as students are getting back to clinical rotations, it's a challenge, right? What does their learning look like now? Does everybody have to be tested? How often do they have to be tested? Should we have 15 people standing there in an ICU on rounds? We don't congregate that way now for meetings and things. And so it's been very challenging, and I feel bad for the education, for the schools, because there's really no good answer to this, but I think the safety and the well-being of everybody has to come first. And so, unfortunately we have to think of alternative, creative ways to provide the education to students.
Yeah, we even are seeing now students that are on rotation. One is we've had to cancel some types of rotation because there's no space for them. So some specialty rotations that have very small provider workspace, the clinical leadership, has asked that there will be no rotations for the foreseeable future just because of the concern of people being together. But we have had students coming back positive or having exposures in the community that now they're going out on quarantine or whatever, but that poses risk to our own staff and our patients. So it's really something that we're continuing to look at every day. And, you know, as these things happen, unfortunately, the patients come first or staff comes second. You know, PA education comes third when we're in the middle of all this stuff. And it's unfortunate to speak like that, but it's the reality that we're in right now.
Yeah.
We're right at 2 o'clock, but we do have 3 more questions. And I think you did touch on the PPE, so maybe we can focus on the other 2. Will any of the new processes remain in place after COVID? Did you find any new workflows that you prefer?
Do you want to go first, Jen?
Yeah, sure. I mean, I think after, you know, it was very clear that certain things will go back up if COVID. I'll give you just one example because we don't have a lot of time, is our prone team. We created a whole separate prone team when the volume of our COVID patients in the ICU was up exponentially. As many of you know, it's sheer effort and a team effort to put someone prone that's intubated in the ICU. And you need a lot of bodies, and it's a risk from the respiratory component, and you really need some key players there. And so we had to create a whole separate prone team for those patients that we had to put prone in the ICU. And I know that if we did this again, that is the one team that we would pull together that was key in making sure that these patients had been proned correctly, and we could do it very quickly and maintain safety for everybody, and they were trained to do it. So that's just one example of the many workflows that we will keep up and going, as well as, you know, as Chris I'm sure has too, we've acquired many new jobs out of this. And so, you know, one of my job right now is I'm in charge of COVID, organizing COVID testing across the medical center or across the system as it continues. And so that will be maintained for a very long time. We don't know when that will come down, but all of our drive-throughs and our point of care testing and whatever testing, we're really trying to centralize what that looks like. And so those are the operations that will continue for some time.
Yeah, same, you know, the teams that we formed during COVID, I've been asked what would I do differently. I said probably nothing. I felt like what we did during COVID was effective and you know, efficient. And the teams that we created, whether they're central line team, proning team, mobility team, those are all things that are part of our ongoing new team meetings that we're having as part of COVID planning and resurgence planning. And there are many things that we would do again. There were, during the first 2 months during COVID, we changed what we did almost daily to where at the end of our volume surge, we were in a very good routine where, you know, where our successes and failures were put together and developed into a robust system, which I think we would redeploy again. That's those same strategies. We were unable to learn from our other USA health system colleagues. The only thing we were learning from was physicians and hospitals in China and in Italy. We didn't have the fortune to go have someone else go through it. We just went through it ourselves and then allowed everyone else to learn from our challenges that we had. And initially it was COVID testing, then it was the treatment and care algorithms and everything else. So there's a lot of stuff that we now know that we didn't know 3 months ago. We learn something new every day. And it's really important that we continue to learn from each other. And that was the purpose of this talk, to offer up to everyone.
Last question, what were the average ICU AAPP to patient ratios in your unit?
That's a really hard question to answer. They were very variable depending on what the staffing was in the unit. Some had 1 to 8 to 9. Some had very solid ratios, but those solid ratios of 1 to 3 or 4 were an intern, an inexperienced PA, a fellow, or whatever. We matched team members to 12 to 15 bed ICUs to manage those ICUs for what the skill sets they had. And then we just worked through what those challenges were every day.
Agreed. It was really based on staffing, similar to Chris, and we were going through really at the same time was the staffing availability. So what residents we had? Did we have a senior resident, a junior resident? Did we have an experienced ICU APP or a non-ICU APP, as well as attending, whether it was an ICU attending or whether it was a surgical attending? And so the ratios were really adjusted based on the staffing model that we had in the unit during that time. And really this changed all the time. So as we continued and people came in and out and fellows started to rotate off and all kinds of things, we adjusted and did the best that we could. And sometimes we were overstaffed and sometimes we were under. So we just really had very close communication. And with provider redeployment, we met all the time. We had a big meeting once a week. We always talked about all of these things, but it was really all day long. We used Teams chat feature, and so had really kind of real phone time chats when people were calling out sick or what have you, and we would make adjustments that way. But you have to be fluid. There's no, as I've told people throw ratio at me all the time, and I said, listen, there's no handbook for a pandemic. There's no national benchmark. You can't give me a benchmark for a pandemic. You really just got to do the best that you can. The normal ratio is 1:4 to 6, depending on acuity and what you're doing, and adding staff and team members from there, and you make adjustments, and you do the best that you can do. And I think the good news is, and at Chris's institution and mine, we had very good outcomes. I mean, for what we had, and we had the APPs. I think the big lesson learned from this is that advanced practice providers, and especially PAs, have the skill set to move and translate across specialty lines. They had great outcomes. The patients were safe. They were well taken care of, given their pandemic situation. And it was a great way to show the value of advanced practice in a time like this. And so, I think it is the one good thing that comes out of the pandemic is really the value of the advanced practice provider during a time, during this time. And, I'm sure Chris feels the same way with his organization too.
Great. Thank you so much. Those were really great, helpful tips. And I know that we went over a little bit, but I think the robust information was important and it was definitely worth it. Chris and Jen, I want to thank you so much for taking the time out to share all of these techniques and your knowledge, and thank you for everyone joining us. This will be available on our COVID webinar page in a couple of days. So for those who want to spread the word, it's on demand and it will be free. So thanks again for all the information, and thank you everyone for joining today.
Welcome. Thanks everybody.
Bye everyone. Have a great day.